All right. Once again, here we are for another Down Fracture podcast, a podcast for talking jaws. Dr. Sam Bobek from Seattle Jaw Surgery. How's it going, man?
It's good. Um, let's see. You seem like you're in a tropical location.
I am.
Nice
Um,
background on the beach.
it it is. It's a little windy, a little humid, but I'm okay.
Nice. I think
There's
we
worse
both
places to be.
were away this weekend. What were you doing?
Um, I'm not away this weekend. You're going to the meeting, right?
Oh yeah, but this last weekend you were traveling, were you?
Oh yeah. I went to Texas for a little while to see some friends and
Nice.
have a good time. And
Glad you
that's
made it
about
back.
it. Yeah, me too. Getting acclimated back to real world stuff, but here we are. So Down Fracture Podcast at gmail.com. We got some more emails. I do my best, and I know I forward them to you, Sam, a lot of times, and we try to reply when we can, but we do appreciate it. Got email from someone over in the UK last week asking about some stuff. Did you see that one?
Yeah, no, it's great. I really I'm with you. I like hearing from people. So some tips that people have or some ideas for topics or even a case or something. It's good to see that stuff.
Yeah, I mean, I'd be interested to, as a way to transition into our topic, which is rubber bands and jaw surgery today. I feel like this is something where you're going to get a lot of variation in how people utilize these or don't utilize these. And maybe we'll get some replies, get some info.
Yeah.
Might be useful.
Rubber bands and jaw surgery. I like this topic because I think that this is one that you just kind of figure out as you practice, right? Like I don't know of an actual resource to really drive you in how to utilize rubber bands other than experience. Do you know of any?
No, I completely agree with you. And as we said before we came on here, I'm of the opinion that a lot of people just throw these things on there because everyone else does, or this is the way they were trained, and often maybe don't even have a specific purpose beyond the quote unquote, hey, I'm just giving the jaw a little support in the immediate post-operative period. What do you think about that?
Yeah, no, I mean, I think there's different philosophies of how rubber bands are used after surgery. Do you use them during surgery?
I don't. You're talking about for MMF during fixation?
Yeah.
No, I don't. I know you and I have talked about this years ago, and I think you were at one point, are you still doing combination of wires and bands?
Oh yeah.
Hmm.
Yeah, I like
Walk
that a
us through
lot.
that. Walk us through that and the rationale.
Well, yeah. So I mean, I think with rubber bands, during it's a little different philosophy than after surgery. During surgery, I'm using it really just as backup for wire loosening. Because you're not like stretching your wires, right? Like you put a wire in, it's tight and it can loosen a little bit, especially as it kind of like settles into the splint and that sort of thing. And so rubber bands are kind of nice because they give backup support for that. Um, I don't know, I had an intermediate splint today that I wanted to make sure that the occlusion hit on the sevens first. There's an asymmetry case. Can't change that sort of thing. And so I put an abrasure wire between the sixes and sevens, and then I put rubber band on the other side. Same sort of thing, like a little bit. I just perceive it as a little bit looser fixation, and then a backup fixation during surgery.
Hmm.
So, like you put it counterclockwise. You really want to seat the anterior teeth, so you use wires to really tighten that in. Counterclockwise mandible first. Um, and you just use rubber bands and back, right? Because the forces will push the teeth together anyway, and you can kind of mix it up in that way. That's generally how I use it, just to kind of fudge the surgery in either direction. You should try it out. Rubber bands are pretty nice.
Yeah, I mean, I'm sure it wouldn't hurt. I mean, the only thing that kind of comes to mind as a potential negative is if you're utilizing them with any amount of force to where they're actually helping the bite close down. I mean, I'd have some concerns on the amount of force on my IMF screws or on a bracket or whatnot. I mean, do you frequently encounter that, or is that not an issue?
Well, I mean, I don't think rubber bands. I mean, you can go up and down and really like stretch the rubber band to maximum. Generally like latex ones. Latex seem like they tear less, by the way, during surgery.
Hmm.
Um, but I mean, I'll take whatever the hospital has, right? Um, I think to me, probably the main reason to keep away from them would be that they're not radio opaque, right? So it's not a bad idea to count rubber bands or to make sure that you don't lose one during surgery. Kind of the same with wires. I know that's commonly overlooked. That's probably for a different time. But during surgery, rubber bands don't seem to be popping off brackets or buttons to a high degree. So
Hmm. I mean, just at some point, it kind of raises the question of like, how much do you need? Like, I mean, if you're already doing IMF screws or wire loops on braces and maybe embrasure wires, like, I mean, where's your cutoff point? Like, how many things you gonna add there,
sure.
Jimbo?
Yeah, I just see it as kind of backup. And I mean, if you have embrasure wires, you probably don't need a backup. But I picked up rubber bands during surgery, I think in fellowship, maybe residency as well. And just as time has gone on, I've just kind of appreciated their use to kind of settle in the occlusion and kind of bias my intermediates in whatever way I wanted them. So anyway, rubber
Sure.
bands, just be careful during surgery. But generally, when we talk about rubber bands, we're talking about after surgery, like what you're saying, right?
Right.
Yeah. So rubber bands after surgery. What kind of general rules do you use in terms of not even specific teeth? Generally, how to use rubber bands after jaw surgery?
All right, I'm going to throw this at you. I generally have a philosophy that if I feel like I've fixated things well, and the occlusion is spot on, I often will not even use rubber bands, with the exception being TMJ replacement, where I do think, I have had patients dislocate from a prosthetic the first week after surgery. So I think giving some resistance of support in those patients is essential because that is a real thing.
Sure.
But I almost make an attempt to not use rubber bands, which is the opposite of how I trained, which is the opposite of how it was when I first came out in practice. I feel like if things are spot on, if I got one or two screws in the mandible and a plate, or I got really good fixation in the mandible, I felt like the fixation was solid in the maxilla, and my occlusion looks like it's spot on, I will not even put rubber bands on that first week. Is that crazy to you, or do you do that sometimes too?
I mean, it's not crazy. I generally think of rubber bands the first week as being the time that I'm actually okay with them not wearing it. I mean, because anxiety after surgery happens frequently, and I prep people with that in terms of giving them the heads up to take off the compression dressing off their head or take the rubber bands out of their mouth. Just leaving the teeth apart can help out a little bit with claustrophobia. And so from that standpoint, I want people to be comfortable. Yeah, I think rubber bands initially are really just kind of holding the jaw in place because if people don't seem stressed out, it does seem like some people like the stability, like just kind of like keeping it a little tighter. Um, but it's
Yeah,
really dependent on the individual.
yeah, they don't get it. I've had patients comment on it too, where they've said, "Oh, I think the rubber bands actually helped," yada yada yada. But the reality is, they don't get it both. They don't get both, right? They don't get it both ways to say. I mean, how do you know the rubber bands helped? It's kind of difficult for them
Yeah,
to
you got to
know.
feel them out. But I agree. I mean, straightforward case, mandible advancement, maxilla up or something. Um,
But I,
do you
I
really
think
need
the
rubber
point,
bands?
yeah, I mean, I think to get to your point of what you were asking is the way I was taught, trained was you utilize the rubber bands to kind of support your movement. So, like, let's use a simplistic analogy. You're bringing the mandible forward. So you have a class two case bringing the mandible forward. You would run class two elastics to give support to that movement.
Yeah,
That's
class
how I
two
was kind of
elastics.
trained.
For the residents listening that may not know, hold the lower jaw forward. So it's lower six, upper three, generally.
Yeah. Or, I mean, yeah. So, I mean, the other way to think of it is if you think of the orientation of a rubber band, just like the occlusion. So the maxillary is further anterior than the mandible, but
Yeah.
however you want to think of it.
Yeah.
So is that what you were taught too, or?
Yeah, totally. Yeah. I mean, supporting the advancement or the setback, right? Um, in a single jaw surgery, I think that's true, right? Single jaw, non-segmental mandible, segmental maxilla, none of that. Just one piece mandible. I think that's a pretty good rule of thumb. And in terms of supporting um the jaw, it's also I think it serves as a good reminder to the patient in terms of not biting or chewing, and then helps them kind of like learn the way the teeth fit. Because I know your patients don't have this, but some of my patients have some numbness after surgery, and so they have some different sensation in their teeth.
Bizarre. That's just
It can be
bizarre.
hard to kind of like find the way the teeth fit. And so, people who don't wear rubber bands sometimes show up at 1 week and, their occlusion doesn't quite look right. But if you're confident about it in the OR and it looks solid, then, you can regain that once you start kind of helping them learn their new occlusion. So,
How tight are you putting them? I mean, because generally when I would do it, I would just do kind of light guiding elastics to where I don't.
yeah, that seems like a variable one. I personally don't keep people pretty tight after surgery. I typically have just one rubber band on either side. I tend to just use heavies. Prior to this one, I actually grabbed the rubber bands just so I can speak accurately to what I'm using. But it's 6.5 ounce rubber bands, and they just up and down. I don't make it too tight because I want people to be able to take them off. And generally at the threes, sometimes it's a little triangle, upper three, lower three, four, midline, open bite cases, those sort of things. I just think with rubber bands, there is harm potential with rubber bands, right? So
Absolutely.
there's some trouble afoot with rubber band use. So shouldn't just reflexively use it. So what kind of trouble have you seen with rubber bands in the first, let's say, week or so?
Well, I mean, I think the point I was going to get to of why I would maybe try to use them is if they're not necessary and they're not having a specific purpose, yeah, they can do harm. You touched on a few things that I've encountered: patient anxiety, patients not being sure if did I have a rubber band on both sides and where was it? Is it still in the right place? Did I swallow it? All these sorts of kind of anxiety that comes along with wearing rubber bands. I worry about oral hygiene with them. They typically run near your incisions sometimes, and they tend to accumulate debris and gunk and whatnot. And whenever you see patients at 1, 2, 3 weeks, oftentimes where they have the most debris accumulated is around these elastics. I worry about things coming loose. I worry about non-unions because of repeated micromotion with pulling on these segments, especially in segmental surgeries. So, I mean, all of those things that when I've encountered those problems as far as like non-unions and other things, I can't specifically attribute it to elastic usage or non-elastic usage, but you got to think it could be something that plays a role in that, wouldn't you think?
Oh, for sure. Yeah, I mean, because our general elastic use after surgery is the first week we just tell people leave it in, not to get
Mhm.
fancy. If you need to take it out, that's fine. We give people backup rubber bands, but having them put it on a specific bracket just stresses everybody out, right? Like, I mean, like you're saying, it's already stressful enough after jaw surgery. You shouldn't be fussing over which hook and getting flashlights out and all that stuff.
Pulling on your incisions,
Yeah,
all that stuff.
typically, because we tend to see people at week 1, 3, and 6, and then 6 months. But our 1 week instructions, we switch them over in the second and third week of recovery to wearing rubber bands when they're not talking or they're not eating. So at nighttime and when they're just downtime. So I want them taking it in and out. I tend to give people a prescription of rubber bands, like where to place it, and that sort of thing at the 1 week visit. So we start getting a little fancy with rubber bands. Because I do think in a week, you can start using them for either supporting the advancement. So like let's say a maxillomandibular advancement case, generally what changes after those cases is posterior open bite, right? And the maxilla tends to drift back. So, run of the mill centimeter advancement, let's say 5, 7 degree counterclockwise rotation. The unstable movement there is the posterior maxilla down and the maxilla forward. And so, running elastics appropriately to kind of maintain the occlusion there. But I do want to take them off because people talk with rubber bands on, I think is a problem. I really do. I don't think it's like a word or two, but I think you've seen people just as I have that seem completely unrestricted with jaw movement with a rubber band and just watching them stretch their mouth like, hey, can I take a look? And, they open to like 35 with a rubber band on either side. And I'm thinking, it's really a little bit more force on the bone than I'm hoping for. So taking the bands out is generally it. At our 3 week visit, we tend to sell splints in and segmental surgery then, but it turns into nighttime rubber band use, and then the orthodontist takes over at 6 weeks. How do you approach it in the first 6 week recovery? Pretty similar, or you mix it up a little bit?
Somewhat. But the other point I would make is to go backwards, and then I want to come back and make sure I answer what you're getting at is the kind of scenarios where I choose to use rubber bands in the immediate like post-operative period, so like in the operating room, is that scenario that maybe it's just me and doesn't happen in your practice, but like you you fixate things on your second jaw. So like you've already done whichever jaw you're doing first. Typically for me, that's mandible. So then I'm doing the maxilla. I cut them out of MMF and I'm looking at the bite and they're hitting well in the splint. They look like they're hitting where they're supposed to be for the most part, but maybe there's like a little midline deviation or something looks like it's a little open more than it looks like on the picture on one side or the other. That's typically when I would choose to use an elastic. So, like, let's say it just looks like the midline's drifting half a millimeter to one side or the other. I might put some on to kind of pull towards that to try to bring it back. Or if, yeah, it just kind of looks like those premolars are maybe a little bit more open on one side than it looks in the photo. I might run some posterior box elastics on one or both sides for that reason. Those are some scenarios where, although I don't know that it helps, it could be just treating my anxiety at those moments. But those are some scenarios where I would run elastics.
During surgery,
Um,
you were saying
yeah, immediately like after
the
I
first week.
close them up.
Yeah.
Yeah, so I close them up in the OR, and I might put elastics on for those reasons. I'm sure there's some other ones, but those are ones that come to mind. And then in the post-operative period, in the weeks after, I usually do it to try to help with the bite. I don't necessarily do it to support. So if the bite's looking on, I would still continue to really not use them most of the time. If the bite is not on, then I would use them to assist in the occlusion. And then another area that I presume we're going to get into is even trying to take things a step further, where sometimes bonding things onto the teeth, such as buttons or other things, to then run elastics to and from specific teeth to help with
Yeah, I mean
occlusions.
the the rubber band usage for individual teeth. So let's say class 2 deep bite, you tripod and post-op, you have open premolars.
Mhm.
Using a rubber band to bring those premolars down. The opposite is true if the occlusal plane maybe wasn't as level as ideal and you need to intrude some premolars, right? So same sort of thing. So rubber bands can be helpful in that aspect. I generally start that stuff after a week. It depends on the patient, but most people are doing well enough at a week. We can start kind of fine tuning it. Um, most of the time with rubber bands, I kind of like being in charge of that until they see the orthodontist, and the orthodontist takes over at about 6 weeks. Because I think how the orthodontist sees rubber bands is different than how we see rubber bands, both in force and reason for using them. Because I think the occlusion is one of those, supporting surgery is one of those, helping fine tune the individual teeth is another reason. I think it can also be helpful for making up inaccuracies in surgery, like what you're saying
Mhm.
with midline. What I see is like segment tipping, so segmental mandibular, segmental maxillary surgery. Things look good at the end of the case. You apply fixation, everything's in good shape, and then for whatever reason, like the splint breaks or it slips or bracket breaks or something, a segment can tip, right? And the one I see probably most commonly is the anterior segment tipping back, but a canine can kick in and those sort of things. And I think rubber bands are pretty useful for cross arch elastics. So I would put a plug in there for cross arch elastics whenever you take your splint out. So whether that's your 6 week appointment or however you manage that, I find that's pretty helpful. What do you think?
Yeah, I mean, I mean, credit where credit is due here. You're the one who's kind of turned me on to that over the years, and so I do find that it can be helpful. I've had cases, and I think I shared one with you recently where I was, you're on the fence of going back to surgery or not, and you can do some of these things and get things much better. In that case, there were some very specific reasons why I didn't want to go back to surgery, and doing those things significantly helps. And maybe that was going to be a really difficult path to ortho or take an extended period of time, and you can do those things. And even if the occlusion's off and you don't feel great about it and it's not one for the photo album or one that you love sending back to the orthodontist. That way, it's still significantly improved. And so maybe instead of 16, 18 months of post-op ortho, it's 8, 10, 12, and other things because you can move things relatively quickly in that immediate post-surgical period. But I think you should. I mean, I think it would be useful for you, who has probably more experience doing it. Go what when you say cross arch elastics. I don't know that everyone knows what that means. So
Well, so
walk us through that.
what I mean by that is running a rubber band on the palatal aspect of the maxillary teeth to the facial aspect or the buccal aspect of the mandibular teeth. That's to, kind of maintain transverse. You can also get some tipping of teeth, but I think you can use it depending on what tooth you put it on, like an upper 7, and you run it down to, let's say, a lower 4. You can get a little bit of a twist on a segment. And I know that sounds strange, but you take a splint out and there's some shift in the segment. You can use rubber bands to kind of regain some of that. But from a straightforward cross arch, it's really just to kind of help maintain and help settle the occlusion. What you need, of course, is the ability to bond stuff to teeth. And I think that's one that I would put a plug into the elastic discussion as a pretty dang useful thing to have during surgery and then after surgery. So if you're doing any bit of jaw surgery, having the capacity to add your own surgical hooks, so to put on your own crimpable hooks in the OR, and bond things onto the teeth, whether it's Kaplan hooks or buttons onto the teeth, because it is nice, Invisalign cases are the ones obviously that come to mind, or surgery first cases. But even in traditional orthodontics, it's pretty dang handy to just put on a caplet hook. Because sending them back to the orthodontist, it's hard on those guys, and they'll be managing after the fact. 1 week or 3 weeks, bonded, having the capacity to bond something on the teeth is pretty nice.
Yeah, that was something I would completely agree with you on that. And then where did you pick that up? Because the extent of where I got that in training was, oh, we knocked a hook off of the braces, and I need another hook, and we would just have crimpable hooks available for traditional appliance cases. But were you guys bonding stuff in fellowship? Is this real
Now,
world
I think you
experience
just
you
kind of
learned on
got
the
to
way?
practice, and you know what it's like. You have assistants that maybe were at an orthodontic practice, and they were, something like that, I assume. Seems like we've been doing that sort of thing for a while now. But with bonding wires across segmental gaps, like bonding onto the facial, or like the segmental mandible, the picture that you have up, bonding onto the facial of the ones and twos in the mandible. If you're already bonding wires onto the teeth, it's not that big of a leap to bond a button here and there. Um, I think it really
It's
helps,
easier.
right? Like it's not a big deal. And if you can kind of help settle down a little posterior open bite, um, I don't think there's much harm there. So in the 1 to 3 or the 3 to 6 week or even 6 week on kind of um, occlusion management, or settling of the individual teeth, I think it's pretty nice to have those.
Do you get feedback from your orthodontist colleagues about these things, or do they
I
ever?
don't think I've had nothing comes to mind on negative feedback on bonding things onto the teeth.
Who's removing those? Are you removing them before they go to ortho, or you
No, I
did?
just send them back with them. I'll be honest. I would have to bet that they assume they bonded that on there. That's probably sounds bad, but those guys probably have great records and everything. But
You just think they
honestly,
show up with these things bonded on their teeth, and the orthodontist is
some
like, "When did we do that?"
some Kaplan hooks on the back of the sixes and the maxilla, and maybe that those weren't on there. But I generally receive positive feedback on that sort of thing, because I mean you're kind of like looking out for them, right? And you're looking at it a little bit differently than mandible small, bring forward, surgery kind of caveman logic. Which, not to get too fancy on the topic on rubber bands, but rubber bands are definitely facilitated by having places to put the rubber bands, and grabbing some of that stuff in your office could be pretty helpful.
Definitely. Yeah, I'm at that point now where I've slowly accumulated things over time, and I have things to bond, and I bond things, I bond wires, I bond. Usually I just use little buttons that are kind of smooth so that I can place them on the lingual and they don't irritate the tongue too much. But that's where I kind of feel bad sometimes is I sometimes remove these things, but like I don't like, are you smoothing out teeth and polishing teeth with like a dental handpiece or anything? Because
No, I don't have
I
any of
don't
that.
have
So
those
that's why
things.
ortho's better. I mean, my handpiece is all, removed tooth, so I don't want to do
Right.
that. So they have those drills that, just remove the composite. So I think they're best. But yeah, I mean, I think in rubber bands, you can make up some things with rubber bands, but not everything. I think using it to support the recovery or even enhance some of the final results can be helpful. Um, do we ever talk about the trick of taking brackets off? Should we even talk about this on here? I feel like I'll get in trouble on this one.
So I know what you're talking about, and I I would not bring it up.
Okay.
But man, I think it's such a useful tip though.
It is
Um,
handy.
it
Um,
is so nice. I mean, I wouldn't bring it up because one, it's kind of your thing, and so I don't want to take credit for it or be
but
the
the
one who talks
story,
about it.
yeah, the story of this one, because I kind of like giving little tips if people will hear them, but the story of this one comes from a lot of experience working with a clinic. This is in the past. This is not any longer, but I still use this trick, which is they bonded offset brackets on the premolars, and for whatever reason they bonded them upside down like as a routine thing, and so the premolars were always high, and I would send back, and whether or not they were repositioned, like, hey, there's marginal ridge discrepancy on these teeth. Um, can we change these bracket placements? And then the patient comes back after 6 months, and really not much is different. And so I think I wondered what it would be like if I just broke the bracket off, right? And so just breaking the bracket allows for those teeth to intrude. And so, orthodontic offices are always doing their best and they're great. It's just sometimes, they're humans too. And I think strategically taking a bracket off here and there to help out with tooth intrusion after surgery can be super useful. Same with bringing it down. And so if you have a seven that's got a bracket on it, but it's really not doing much up there, you can sometimes bring it down a fair bit actually after surgery with rubber bands. Obviously, you got to be careful with it, but um, intrusion mechanics of individual teeth, it's a nice cheat. So I'd much rather take off a bracket than grind a tooth, by the way. So I don't know if I
Yeah, I
had
think that's what's kind of lost on some people. And maybe I don't know that I've ever had a discussion about enameloplasty with orthodontist, but I mean, it does seem better to not grind down teeth. I mean, not that we do it profusely. I can't ever recall a patient having like attributable tooth sensitivity or problems from it, but I'm sure it happens, and maybe it's years down the road, and we don't associate the two.
yeah, enameloplasty
Um,
is a whole other topic, but yeah, I mean, minimizing that, obviously you don't get crown back, so you don't grow new enamel. So minimizing that makes a lot of sense. And you don't have to adjust your plan, by the way. So have you had one with a tooth that's really in the way, like a marginal ridge discrepancy that's a little
yeah.
good? Just um you just plan otherwise, and then the occlusion looks a little different, but you know what that looks like based off your surgical planning. And then you can, within a week or two, intrude that tooth pretty well if you take it out of the arch wire or teeth, and then it allows the teeth to close down. So obviously it's nice to get that stuff set up ahead of time. But man, once I learned that trick, it made all of those cases much easier, rather than getting fancy with ultra segmental surgery and everything else. So
So what just to make, because again, I'm not sure everyone grasps what you're saying here, but what you're saying is, let's say you have a premolar or two that's above the occlusal plane of the rest of the dentition. What you're proposing is if you were to, quote unquote, accidentally or intentionally pop a bracket off of those premolars and then ran kind of horizontal box elastics in that quadrant, those teeth are now out of the arch wire and the intrusive forces will allow those to intrude. Is that what you're saying?
yeah.
Okay. Because I'm not sure people, I think it's sometimes not an easily grasped concept is once the teeth are no longer a part of the arch wire, they are no longer going to move in unison or have resistance to the forces that you would be putting on them.
Yes. Yeah,
My,
like taking brackets out of the whole teeth moving as one unit can be helpful for moving individual things. You got to remember when they don't have brackets and it's Invisalign and a bunch of buttons, individual teeth can move. So running one rubber band on a tooth will tip that tooth. And so anyway,
Mhm.
understanding how the forces and mechanics of orthodontics at least a basic level, I think is helpful. But right after surgery, there's some grace I think the orthodontists give us, and we can use it to get a better final result.
And then for the sevens, you were saying take the bracket off of the seven and then run elastics on that side to kind of
Yeah,
allow
you
some
know,
intrusive force and
because you've been in
level that out.
situations where like you're on the fence on do segmental surgery because it's a little bit narrow at the sevens, and you think, gosh, seems like a lot to fix, like an edge on occlusion on the sevens. And so you can just run a cross arch elastic, right, to tip that out a little bit. And even if you just hop the cusp, you're in a much better situation when they go back to the orthodontist than you were otherwise, right? Uh,
Mhm.
and obviously that's a hard rubber band to place because from a patient perspective, the ease they put rubber bands on, you should keep that in mind.
Right.
Um, because it's hard, right? Lips are
Yeah,
numb, mouth opening's hard,
running a band from the palatal of a seven is, and
difficult.
expecting a patient to do that consistently, I think
Yeah.
it might be a little bit of a big ask.
So obviously it depends on the scenario, but anyway, I think using rubber bands with some purpose, I think can be good. And I'd encourage all the residents to kind of consider rubber bands a little bit more than we always put rubber bands on the threes, or we always just band people up for 6 weeks. I don't know. You got to go with what your attending's doing, but in real practice, you can utilize it to kind of have a little bit better surgical results.
Or don't use it if you don't feel like you have a specific reason or purpose for it.
Agree on that one. That's great.
What about TMJ replacement? You're
Yeah, I think
using
I use it like
elastics
you do. I
post-op.
mean, yeah, because sneezing and vomiting and stuff can cause the jaw to dislocate. Um, I don't know. With TJR, generally it's a bit of a posterior open bite. There tends to be a little bit of that tendency, particularly when it's coupled with jaw surgery, like doing a LaFord and TJR. But I don't tend to bond anything back on those teeth. It is always nice to have a band back there if at all possible. And I guess my final thought on rubber bands would probably loop back around to hook placement. Um, I think when I was coming out of fellowship or, when I moved to a different town, worked with new orthodontists, that's a common question I get. So for the residents out there, you should have an answer to that question. The answer, I don't know, or I don't care, doesn't inspire confidence. What do you tell people in terms of where you want the hooks? Because it's for rubber bands, obviously also for wires, but where do
Man,
you want
I
some hooks?
completely agree with you. Like that was one of those questions when I came out of training and was starting to do this, I just had the same answer that I was taught of, if at all possible, can we ban the sevens and
You're
put
crazy.
brackets?
You
Yeah,
don't say
all
not
those things.
now though, right?
No, 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 no. I tell them, I mean, really now it sounds like a cop out, and I am 100% aware of what you just said. And I think that is a real phenomenon that surgeons need to be aware of is if you don't have an answer, it certainly does not instill confidence.
Yeah.
Um, but I generally, I feel like I think I've heard you say this before, and I feel similar is I generally feel like I can work with whatever almost at this point. If I don't have something, I'll put an IMF screw in or I'll bond something myself. But generally I would say it's nice to have hooks at midline, canines, one of the premolars and one of the molars is generally what I will say.
Yeah, sure. Yeah,
But
hooks
but
between the ones.
you can't really have too many, so I generally tell them, hey, if you
You
if you
can't.
forget that or whatever, like just put them everywhere.
Have you ever
Um,
seen cases where every bracket has a hook
I've
and
seen
then
every bracket
every
and then
space
every
has a hook on
space.
the wire?
Absolutely. And that's
Man,
just
it's
got to be
like
miserable.
it's a rubber band party. It's like just confusing where to even put wire loops. It's just too many options.
I have, but I'd rather have
Like
that than not
Play-Doh.
enough if that's all I got. But
Yeah, no, I mean, just coming up with an answer, but yeah, so for rubber band use, pretty helpful after surgery. There's a couple situations that can really kind of enhance the final result. And I think having a few different rubber bands in your clinic is a good idea. So anyway, those are my plugs for that part of it. Did we discuss this at do we hit all the different points you were hoping to get on this one?
I think so. The only other thing I would add is, and this is maybe just so far out in left field, is I had a case recently where prosthetics didn't fit in TMJR, and kind of the rule of thumb is put them in elastics or MMF. And what are your thoughts on that? You think you got to do that, or is
Oh,
that too far out in left
yeah,
field for
that was
this
really
discussion?
different. That was you're spending too much time on the beach. You got to get back
I
to the
know.
office. Yeah, I mean, kind of two staging TJR, I think we'll save for another day. But
Okay.
um, yeah, rubber bands. What do you give people anything for tools? Do you give anyone any tools to put them on with? What do you?
Yeah, I think a lot of the times when we order the rubber bands, you can either get them like you can request them for free, or I don't know, maybe we buy them, but there are those little like plastic hook
Yeah, little
tools.
plastic things. Another one to
We
be
tell them,
familiar with. If,
yeah, we
you
tell
know,
them
I
use
think
tweezers or their fingers or whatever they need to, and give them those hooks. But
one of the things I liked about, I mean, there's a lot of things I liked about fellowship, but one of them is you spend a little bit of time in an orthodontic clinic and you get introduced to a lot of the stuff like what do they use for these things? And they've figured it out. Those guys have figured it out. So looking into orthodontic supply stores or stop by your friendly orthodontist to get some tips on putting rubber bands on is pretty good. So
is that what you use, those little hooks, or is that what they
yeah,
used in
I
that
use those
clinic?
little plastic thin things with a hook and a pushing end to it. Then we at the hospital I give people hemostats, but generally people just use their fingers, so barely.
Yeah, I think if you don't use your hands in these small areas and for these things, a lot of times the dexterity you get using your hands is probably easier for most patients.
Yeah,
Because
yeah,
it's
and I
hard to
mean,
look in your own mouth in a mirror with a tool. Like you can't do all of that. Like you can't see, retract, do it. Like I don't know that patients can do that
yeah,
well.
yeah, and definitely patients' capacity to do it. Younger patients, hand mobility concerns, those sort of things. So, but I'm sure people will figure that out. Sweet.
Cool. Well, did we beat this one to death?
I think so. I like it.
No, no old man saying.
No, I don't think we got any of those. But rubber band use. I like this topic. I think hopefully I'll be interested to hear any other tricks that people have when it comes to this sort of thing. So um all right, man. I'm gonna skedaddle. So it was good catching up with you and talking jaws another time.
Likewise, man. Let me see if I can figure out how to stop recording this episode because oh, there we go. I found it. All these software updates make it difficult. All right. Well, till next time, that was another Down Fractured podcast, a podcast for talking jaws, downfracturedpodcast at gmail.com. If you want to send us anything, YouTube, Spotify, Apple Podcasts, all those fun things. Um, we didn't get an old man saying in there, did we?
Next time we'll get to.
You always say that. All right. Take care.
All right, man. See ya.
See ya.